Well, hello, and welcome to a session of interesting cases to discuss with my colleagues and friends in Southeast Asia. We'll be beginning shortly. Well, I appreciate everyone making it possible to meet today rather than on my regular scheduled time. I'm going to be traveling to a special gathering, remembering what I was doing 50 years ago soon. And so I'm getting together with some very dear friends soon. We're going to talk about some bile and biliary and gallbladder lesions. I think in our country, the gallbladder is the most frequently removed organ of the body. And yet, sometimes we can be lulled into complacency because the most common diseases are so common that we may miss some of the uncommon and subtle diseases. So we'll begin with some more common things. This is the first case. And sometimes when they use ultrasound or other things to image the gallbladder, they will detect an intraluminal mass that may be something like this. Now, this may look like chorionic villi or other papillary structures, but this polyp is composed of normal biliary epithelium with a lot of stromal macrophages. And so we use the term cholesterolosis for this condition when we see this, these macrophages in the lamina propria. But we don't recognize that sometimes these lesions can become mass-like lesions and mimic carcinomas. And also they may occasionally be large enough to obstruct the duct. As you can see here, if one of these were to become dislodged, it could easily create obstruction. So sometimes they can be the cause of obstructive cholecystitis as well. Now, you do want to examine them to make sure that there's no dysplasia. And here, even though this looks a little bit busy, this is still a non-dysplastic lesion. So that's mucosal cholesterolosis and sometimes papillary polypoid cholesterolosis. Now, another thing that can mimic neoplasia is a very gross inflammatory change, such as you see here. We have big, large, mass-like areas with thickening of the wall. And as we look in here, we see that there are little clusters of bile pigment-laden macrophages. And so again, we have these foamy macrophages, but in this case, we have other things going on. We have the bile salts, and we also get some giant cell reaction. So here we see some giant cells of the multinucleate type that are reacting to the bile and the debris in the lumen as though it were foreign material. And that's probably because we've broken down the mucosal barrier and these have become lodged in the wall. And you have this very large xanthogranulomatous reaction, which again can mimic neoplasia. Now, usually these patients will have symptoms of biliary disease, colic, or pain, worse with eating or digestion. And at low magnification, you can see why you might be concerned about things like lymphoma. There's a lot of large cells here with abundant cytoplasm, and you might think, well, could this be large cell lymphoma or something like that? So microscopically, this can even imitate a neoplasia as well. So that's xanthogranulomatous cholecystitis. And we'll go on to the case, which is also the same process, a different slide. And here you can see fragments of a gallstone with fat necrosis and this very dense
Anh Thắng ơi,
inflammatory
đâu?
reaction.
Vâng.
And this is, again, a lot of foamy histiocytes here, obviously more histiocytic. And the giant cell reaction, again, is a feature of that disorder. So if you see giant cells in the gallbladder wall, think about xanthogranulomatous cholecystitis as your diagnosis. Of course, like other cholecystitis, this gives you a dense fibrosing process in the wall. But again, you always want to look at the epithelial component to make sure that you don't have dysplasia. And so here again, we look at the epithelium, it looks fairly unremarkable. But as you can see, the muscle of the gallbladder wall has been essentially replaced by a very dense fibrocollagenous tissue. This is, well, I guess there may be a little bit of muscle left here, but a lot of sclerosis and collagen here. So here's another gallbladder case. In this case, the patient had some cholecystitis or had, symptoms of right upper quadrant pain and so forth. And we can see here that the muscle is a little bit hypertrophic. It's a little thicker than oftentimes you see. We have inflammatory reaction here along the adventitia. And this can be deceptive because this inflammatory reaction can sometimes look like it's got carcinoma in it, or it may have some atypical glands associated with it that may just be Aschoff-Rokitansky sinuses that are extending out here and have become inflamed. And that's part of the way that cholecystitis induces this scarring and collagenous reaction to thicken the wall. Now, in this case, we have several of these sort of pericholecystic abscesses or necrotizing foci. These may be related to infection. They may be related to, obstruction of the Rokitansky-Aschoff sinus. And as we look around, we can see that they also produce scarring in the muscularis here. Going a little bit further over here, we can look at the mucosa and again see that here it's not dysplastic. Here's more normal muscle, more normal appearing mucosa. And then here is the example of what's causing that. So you see this diving or deep glandular tissue with the surrounding inflammation here. And so what's happened is that something has gotten into this Aschoff sinus and is provoking the inflammatory sinus out, or inflammatory reaction out in the wall. So it's very good to remember that these Rokitansky-Aschoff sinuses can look a lot like invasive carcinoma. As you can see here, there is sort of a desmoplasia associated with that, this streaming, fibrosing process around the gland. And so in the situation where you have epithelial dysplasia in these epithelial cells, and you see this can look very concerning for invasive carcinoma. But you do have to make sure that if you're going to call it invasive carcinoma, that it's not just dysplasia extending into one of these sinuses. A few years ago, Dr. Ngop and Dr. Zhang in Ho Chi Minh City wrote up our experience with that process and some of the deceptive changes that can be seen. So here's the inflammatory reaction that's involving the surface, where you have sort of a necrosing process as well there. So that's a little bit of instruction about some of the processes that result in this fibrosis and the pitfall of seeing these Rokitansky-Aschoff sinuses in the wall. Now, another a lesion that can be mistaken for this or overlaps with this perhaps is so-called adenomyosis, where you get glands throughout the wall of the gallbladder. Now here's kind of our normal appearing mucosa over here. We see some inflammation here. And when you see this sort of hyperchromasia, you do want to look and say, do we have dysplasia? And so looking at an area like this that maybe looks a little bit bluer is an important part of your exam to make sure that you don't have a dysplastic lesion. And that's because this dysplasia can not just involve the gallbladder, but it can extend into the cystic duct. And so you want to make sure if you find an area that looks a little bit concerning for dysplasia like this, that you don't have involvement of the cystic duct margin. So here the mucosa is pretty well confined along the surface. And I think there was one area where we had started to see some extension. So right here, we begin to see a little island of mucosa that is really pretty much surrounded by muscle. So this is a little bit of adenomyosis, if you will, like we see in other organs where we have a muscle coat. This is, again, a benign feature, but it can provoke a little bit of hyperplasia. It can provoke a little bit of inflammation. So that's a very mild example right there. The next couple of examples, I think, will show you this a little bit more. So here at low magnification, I think you can appreciate that this is thickening the wall, and we see glandular structures along with this. We see the serosal reaction. And here we even see dilated glands out in the outside the muscularis. So here we're seeing glands within and outside the muscularis of this gallbladder. Here's some of these Aschoff-Rokitansky sinuses that are provoking inflammation and scarring. So again, this is a feature that can be seen and can be confusing for carcinoma. So here's a look at these. This is way, way out beyond the muscularis. Certainly this must be or could be carcinoma, but we don't see much in the way of cytologic atypia here. So we say, well, perhaps not. And I don't think this is cancer. This is, I think, a benign process. But this illustrates how deeply pseudo-invasive these glands can be in the gallbladder. Now, you might also call this cholecystitis cystica profunda. Profunda means deep, and cystica means cystically dilated. Well, these are deep glands that are very massively dilated. And so that would be another term that would be also very descriptive of what you see here. But calling it an adenomyoma or a dilated Rokitansky-Aschoff sinuses, the important thing is that you don't call this cancer. And as you can imagine, if you have dysplasia, this becomes a very hard challenge to resist that. Let's see on the other areas here. I think here we've got more of this process. Now you can see that sometimes, like in the colon, where the penetrating vessel is sometimes the area of weakness. And so here, right alongside the vessels, is where these invaginations of the mucosa find it most easy to escape the wall. The gallbladder has a very thin muscular coat, and so it's not very difficult if the pressure in the gallbladder becomes high due to obstruction or some other problem for these little outpouchings to be provoked and produced very readily. Here's another example, this one a fairly trivial one, where you can see there's just a very slight dilatation here as we come into the wall of this lesion. So a nice spectrum of disease, but you still get a little bit of reaction around this, where you get a little bit of fibroplasia here. And here's another one that's open to the lumen. So this one probably hasn't been around very long, hasn't been provoking much inflammation. And so the wall is really not noticeably thickened. I mean, this is really pretty much a normal thickness for the gallbladder wall. Okay, well, here's another example that this one is provoking some thickness and mass effect here. And we'll go right over to this area because as you can see here, we have glands within the muscle. We don't see dysplasia. There's not hyperchromasia here, but here these glands are all scattered amongst the muscle strands of the wall. And then over here, in somewhat of an altered cut, you see a lot of inflammation, some glands out here. It's really not clear where the mucosal surface is. We have it up here, but we may also have it down here. And there's a lot of inflammation associated with this. A lot of lymphocytes and a lot of eosinophils. And eosinophils seem to be a common feature in many inflammatory gallbladder lesions, perhaps due to the pseudoallergic nature of the bile. But you could see if you just had a small biopsy of this, boy, it would be hard to tell if this gland is benign or malignant because it's scattered around with so much inflammation around it. So adenomyosis can be a very challenging diagnosis and can create a lot of both gross and microscopic overlap with neoplasia and something that you need to be aware of. Now, this underscores a reminder that we always want to sample the cystic duct margin when we sample the gallbladder so that we can compare our mucosa here at the margin with what we're seeing elsewhere. And remember that in any biliary structure, you can get these periductal glandular structures that are benign appearing, but can have variable morphology. So here you see a lot of mucin in these cells, whereas here there's hardly any, they're very small, and so forth. So in some settings, this type of polycystic duct or common hepatic duct or common bile duct glands can look a lot like carcinoma, particularly because many cholangiocarcinomas are very well differentiated. So here's another example of this adenomyomatosis with massively dilated spaces. Here they've inked the outer surface because they're concerned about possibility for neoplasia. But as you can see, it's just this dilatation and adenomyomatous change or polycystitis cystica profunda change that is creating this dilated interconnecting cystic spaces that make you wonder where the lumen is and where the margin's going to be, or if this is cancer or not. Okay, so we've had several good examples of this. So one of the things that can overlap morphologically with this finding are some of the cystic neoplasms of the pancreaticobiliary tree. And so here is one of these that can be mistaken for adenomyosis. Here you see a thickened wall in areas, but at low power, notice how you also have this sort of bluish purple stroma. And as we come into this tissue, you'll see that the spaces here are lined by nice mucin-producing epithelium, basal nuclei, pretty bland appearing, not maybe a little bit crowded, but not too worrisome. But notice this stroma. Notice how distinctive this stroma is. Do you recognize what this is? Well, there's a clue up here, and that's another feature of this lesion when we see it in the pancreas, for example. We see these somewhat serpiginous, hyalinized, collagenized scars. And so if I gave you a high magnification view of this and told you this was from the ovary, you'd say, oh, this is a corpora albicans. And that seems to be the best analogy for this. This is a mucinous cystic neoplasm, which is which is more common in women than in men, but does occur in men. It's much more common in the pancreas than in the gallbladder or the biliary tree, but it does occur there. And so if you examine enough gallbladders over your lifetime, you may well find one. And this is the characteristic features: mucinous spaces, ovarian type stroma, and occasionally these hyaline corpora albicantia like scars. So here's another area of it over here. Now, sometimes this stroma is quite abundant, as you see here, and sometimes you just have a very small sliver of that kind of stroma. So I'll show you some more examples, and this includes a few cases that have been, how would I say this, missed. This is not a life-threatening diagnosis if you miss the diagnosis per se, but it is nice to make the diagnosis rather than to be embarrassed by showing it to someone and having them correct you after the fact. So here's one where there's quite a bit of this tissue, and you can see the mucinous spaces. Now, this is a potentially malignant lesion, and so you do have to look for evidence of dysplasia or atypia in these epithelial elements, and rarely you may get carcinomas that derive out of this. The stroma here usually is positive for hormone markers. That's a helpful feature. So if you have estrogen receptor or progesterone receptor, and you're concerned about whether this is that kind of a lesion, you can do those hormone stains. Here we see a little bit of that scarring that I just described in the other one, a little bit more over here. Again, those are features of this lesion. Size-wise, in the pancreas, they can reach several centimeters in size. Usually in the biliary tree, they create symptoms before they reach a very great size. If the mucus breaks out into the stroma, you may get a little bit more reaction or inflammation associated with it. As you see here, there's a little bit more dysplasia associated with an area of rupture of the cyst. Here's another example, and this is an example where, as you see, there's very little of this distinctive stroma, just a very small trace of it here and here and here. But this is a case that was missed. So this was entered into the database as a biliary cystadenoma rather than a mucinous cystic neoplasm. But I think you'll see here that this is that same distinctive stroma. We have areas of scarring and hyalinization. And so this is a mucinous cystic neoplasm that is, again, thickening the wall of the gallbladder rather than being a cystadenoma. Now, notice here we also get some sort of reactive changes. We have cholesterol clefts. So there's been some inflammatory reaction, some hemorrhage or something that has gone along with this. Now, of course, if you don't have much in the way of atypia, you're not doing anyone any harm if you don't call it a mucinous cystic neoplasm, but you don't get any guru points if you don't make the diagnosis either. So we want you to look sharp. We want you to be able to impress your colleagues that you know what things are. Here's one more example, and this one is actually within the liver in the biliary tract. So here you can see liver tissue, that sort of nodular tissue. Up here, we have a little bit of inflammation associated with the portal tracts and so forth. There is nice biliary, or excuse me, hepatic parenchyma, a little fatty change. And here you see this lesion, which is a dilated cystic structure with a bit of tissue within the lumen. And so this was a case where they thought, gee, this looks like a neoplasm, something that we're going to need to take care of. And so it was resected because it was amenable to that. And the diagnosis is here, fortunately for the patient, a very benign one, mucinous cystic neoplasm without evidence of any high-grade dysplasia or carcinoma. So have your eyes open to the epithelial component and don't overlook the distinctive stroma. Look for areas of dysplasia or epithelial atypia. And if you can find them, look for these very characteristic scar-like areas. Those will be helpful to you in the diagnosis as well. This is the other portion of this lesion, additional sections. And here, just highlighting that you may get very little of this stroma. So here we have the wall of the lesion, and there's really no stroma to it. So they can biopsy these things sometimes and not give you the diagnostic features in the tissue unless you're really, really looking hard for it and you remember to stain, because here's just a little tiny bit of that distinctive stroma here with the hyalinization and so forth. Okay, well, this is some interesting material. I hope that you appreciate this sort of thing. This is, I think, more of the same case. I'll just skip forward on this. Here's one in the pancreas, illustrating again some of the spectrum of disease, pancreatic parenchyma here, and then what's inside the lesion, and here portions of the wall, which I think you'll see has a lot of histiocytic reaction. So there's you've lost some of the mucin here, so it's not distinctive there. But as we come around to other areas of it here, I think you can begin to see that here we have the diagnostic features. Bland mucinous epithelium, distinctive spindle-shaped stroma, occasional little hyaline or fibrosing scar-like areas of that lesion. So this highlights some of the variability in terms of the morphologic thickness of the stroma, prominence, and the kind of reaction that you can get as the wall becomes thin in certain areas, you may lose the distinctive stroma. We'll take a look at here what was inside. Here is, as you can see, there's been some hemorrhage and so forth, some degenerative changes in this. It could almost look like a pseudocyst. or some other sort of cystic neoplasm or something like that. Nothing here particularly distinctive. So you have to sample these lesions well and recognize that sort of the reaction sometimes can be deceptive. Okay, well, here's a little bit of a gem. I don't think I have seen this very often. I hope you haven't seen it very often, because we don't get resection specimens for this particularly often. But this is kind of an incidental finding. So here's a bit of liver, and we can see here we have a bile duct that's somewhat inflamed and thickened. You see there's a bit of fibrosis around there. Here we see so-called flame structure, where we have a granulomatous appearing lesion with some palisaded histiocytes, some inflammatory cells like this. And I've seen this a few other times, one other time in a liver biopsy from Hanoi, but we never found the etiology for this. I showed it to a number of experts, and no one could identify bugs or anything in them. But we didn't have much else in that sample. And so I'm wondering now in retrospect if finding those sorts of eosinophilic granulomatous lesions in the liver was in fact related to this particular organism that we find here in the liver here. And as you can see here, we have a bile duct with lots of nice periductular glandular structures, and we have something in the lumen here that looks like it has a little bit of a tubule there, some connective tissue, maybe some surface tactile sorts of things, a little bit of a hyaline basement membrane here, some maybe circulating cells with nuclei in them. And as we look over here, we can see that there's a very nice gravid uterus here with just millions upon millions of eggs. And so these eggs actually are quite distinctive. These would be identifiable by most parasitologists. If you were to see them in a stool sample, for example, these would be identifiable as Clonorchis sinensis. So we don't usually see the whole fluke, and certainly don't see it in situ like this very often. So I thought this was a very nice, unique case to see the Clonorchis sinensis fluke in its parasitizing state, with its organs intact and so forth. I'm going to do a special video on this just to talk more about this entity, but I thought you might get a little pleasure out of seeing this. Have any of you ever seen this in your cases? The association with these eosinophilic flame-like granulomata, I think, is quite remarkable. Well, while we're on that topic, here's another liver biopsy where the patient had some symptoms, and there was some concern about what was going on in their liver. As you can see, it's a little bit of inflammation here. And as we look through here, there's one little structure here. It looks a little bit funny, not clear what that is. And as we go along a little further, well, where did I hide it? Let's see if I can find it. There it is. Let's go right there. Lo and behold, look at this. We have another little parasite here, an egg of the Schistosoma japonicum that can invade the biliary tree and produce cholangitis, produce eventually cirrhosis even in these situations. And you can see here, the inflammation is kind of a mixed pattern of inflammation. We have some eosinophils, we have some neovascularization, some lymphocytes, and so forth. So we might be concerned to mistake this for something like autoimmune hepatitis or some other drug reaction, drug-related liver disease or something like that. But here in this case, the cholangitis and the inflammatory pattern, and then ultimately the finding fortuitously of the deposited egg. Now, it might be that on other levels, we would have found other evidence of these eggs out in the tissue as well. But this is a unique liver biopsy. I certainly have never seen this before. I thought it'd be good to share with you. Okay, well, let's come back to the gallbladder. We've talked a lot about the benign diseases. Let's spend a little bit of time talking about how dysplasia looks and what neoplasia looks like. So we'll focus to begin with over here. And I think you can see here it looks as though we have fairly bland, normal appearing biliary epithelium. So we go from that appearance and we move towards the lesion in question. And as we come along here, I think you begin to see, and maybe you can see right here, the contrast between this gland and these other glands. This gland has hyperchromasia. It has a little bit of glandular crowding, and there's just a little bit more blue to the cells here than the adjacent ones. So you might be concerned, could that be dysplasia? As we move a little bit further on, of course, here we begin to see stuff down in the wall, but we don't see more direct dysplasia in this situation until we get to here, where we begin to see a very well-differentiated carcinoma. And here, there's only very, very subtle differences between these neoplastic glands and the more benign-looking glands next to them. The neoplastic ones may have some neutrophils, may have a little bit of pleomorphism, but really a very minimal deviation type of pattern. And yet, when we look at this at low magnification, you can see we obviously have a neoplastic proliferation. So let's look here at this area, which looks a little bit like that adenomyomatous area that we looked at earlier. What's different about it? Well, one of the differences is the structure of these glands. Notice the variable size and shape, the small glands, the big glands, the mucin, the inflammatory changes, and the desmoplasia. Those all look a little different than what we saw with adenomyosis. And so we're seeing areas of more poorly differentiated, almost signet ring cell type patterns here, some of these cribriform areas in that area. Then, as we can see, this penetrates outward, and it has more of this very poorly differentiated morphology with small mucin-filled spaces, a few more signet ring type cells, and this very poorly differentiated appearance, not looking like the well-differentiated stuff that we have on the surface. So this is one pattern. One of the remarkable things about gallbladder cancer is the number of different types and patterns that you can see. And so I've got several cases hoping to show you some of the different morphologies that can be seen. So this is one where I don't think we really have much in the way of surface dysplasia. And as we see in the stomach, for example, very often the discohesive types or the very poorly differentiated types, the signet ring type cancers, don't have an intestinal type of dysplasia. And that's what we're seeing here. We're not seeing a true intestinal type of dysplasia that we might see with some other types. But rather, we've just got the development of this poorly differentiated infiltrating neoplasm here. So how do you detect this grossly? Well, any area of abnormal thickness or thickening in the wall, you should look for that as you examine the gallbladder and section that area so that you won't miss these kinds of lesions. Okay, well, here's another example, this one in the bile duct. And this is an example of a cholangiocarcinoma that's occurring in the bile duct, but it again has it has a little bit different morphology. So very often cholangiocarcinoma is characterized by quite well-differentiated cells and small glandular structures. So these sorts of structures, small tubular glands of variable size, don't look very worrisome, but these can be cholangiocarcinoma. And when this is the pattern in the gallbladder, it can be easily missed. We have had a case several years ago where the cells like this were found in the peritoneum a year and a half after the patient had had a cholecystectomy that was reported as benign. But when we went back to that cholecystectomy, lo and behold, there were cells just like that in the cholecystectomy. The other feature that we're seeing here, however, is the development of some of these more solid areas with slightly larger cells, more abundant cytoplasm, more oncocytic or even hepatoid appearing. And so here we can see areas of more solid growth, as you see here. And if you'll remember from when we talked last year about some of the types of liver cancers, hepatocellular carcinomas and cholangiocarcinomas, that there is a variant which includes both cholangiocytic and hepatoid differentiation that will express some markers for cholangio as well as some hepatoid markers. And one of the morphologic hallmarks of that is the development of more solid invasive neoplastic areas in various proportions within the tumor. So here we see these large spaces, some intermingled small spaces, and then as we come to the periphery of this tumor, we can see that we're having a more solid pattern of growth. Here as we come into, here you can see more confluent glands, more solid appearing tissue. So I think this is one of these combined cholangiohepatocellular carcinomas. And here you can see this more hepatoid appearance to the tumor cells. Abundant eosinophilic cytoplasm, as you can see, somewhat oncocytic. So that's another pattern that you can see. This is a case from within our hospital fairly recently. And this is one that is quite interesting because it has areas that appear to be sort of the high-grade dysplasia. So here is an area adjacent to the tumor where you see within the mucosa kind of a high-grade dysplasia. These nuclei are enlarged with macronucleoli and abundant cytoplasm, some karyorrhectic debris, but not invasive. So there's a nice glandular element to it here. And here you can see more of this dysplasia. And then as we come to the center of the lesion, the invasive lesion, we see that here we have more of this glandular component. And then look at this, it becomes much more solid. As you can see here, we get virtually solid sheets of undifferentiated cells. And so this is a case where we have the beginnings as a sort of poorly or as an intestinal type, but then it sort of de-differentiates or it becomes more aggressive into a more undifferentiated type of tumor. And in fact, we discovered that this was manifest in some of the immunohistochemical findings where these columnar areas, which were often near the base of this area, had a different immunophenotype than these more poorly differentiated solid areas that we've looked at here. Now, of interest, this solid and dedifferentiated part is mostly exophytic. It was growing into the lumen. And we actually had to look quite closely to identify areas where we would have invasive tumor. And so we saw some here. And this could have been an involvement of a Rokitansky-Aschoff sinus, because you see we still got muscle here. But we felt like these areas over here were unlikely to be in situ extension of the tumor, likely to be extension of tumor into the adventitial fibrous tissue. Here you see more of it here, more of it here, well away from these Rokitansky-Aschoff sinuses in this case, and producing a little bit of a serosal reaction, but without any identifiable neoplastic cells on the serosa. So I'll show you a couple of the immunostains from this case. I believe I have them here. So here is, I think you'll see here, we have a nuclear positive control here in colon. This is a CDX2 stain. So just out of interest, we did this to see if we had an intestinal phenotype here. And as we look at our tumor, okay, let's find the areas of concern. You can see that some of our cells in the more columnar area have a little bit of this CDX2 marker. But the more solid tumor, as we go over here, is much more strongly positive with this. So more strongly expressed in that area of the tumor. If we look at another marker, CK7, I believe this is, we see that there's no staining in the diffuse parts, but we have a little bit of staining in the more columnar, diffuse scattered cells. So I don't know if that was what I wanted to show you. Anyway, we'll go forward. So here's another cholangiocarcinoma, this one in the cystic duct right at the juncture with the common bile duct. And here you can see one of the challenges of this lesion. So when people have an obstruction, as this patient did, and they get a stent put in, that produces a lot of secondary cytologic atypia. So many of these glands over here look quite atypical. And in fact, here you see, maybe this is dysplasia. We're not quite sure. Well, you can see there's some invasive cells and there's some small glands here that look a little different. So it's likely that what we have here is a benign reactive tissue, and then we have these infiltrative invasive glands that you can see here that are the carcinoma. In addition, we also have here on the surface in other areas here, this very pronounced atypia. And one of the features that we use in cytology of biliary brushings and so forth is finding a dual population of cells. So finding cells that look like this with clear-cut atypia, not much in the way of mucinous cytoplasm, and being able to contrast them with more normal appearing biliary epithelium helps us to arrive at the diagnosis of at least in situ malignancy. But this is a very subtle case because it does have those infiltrative glands I just showed you. And then over here, we again have, some normal structures, and then this pattern of desmoplasia with infiltrative glands. Now you can imagine the difficulty in evaluating this if you had a needle biopsy that, say, included this and a couple of these. And you would have a difficulty being sure what we were dealing with. In these biliary biopsies with obstruction and so forth, we don't get very big tissue samples. And so we will often use evidence of an infiltrative pattern as demonstrated with immunohistochemistry as evidence for neoplasia. And that's very helpful when these type of cells light up for cytokeratin in a clearly infiltrative pattern that seems distinctive from the surrounding desmoplasia or the surrounding benign glandular structures. So they're another sort of inflammatory desmoplastic process here. But you can see in this, these glands down here, we're probably not concerned about these being malignant. But yet, right here next door, here's some of our suspect cells. So very subtle. These could be mistaken for smooth muscle or something like that. So that's where immunohistochemistry can be very helpful to you. So here's another example. Well, I'm going to skip this case. Let's just go on. This was an obstructive due to nerve proliferation. So we'll talk about other things. Here's another polypoid lesion, exophytic into the lumen of the gallbladder. And this is, as you can see, forming sort of an organoid pattern, chains and solid areas, small cystic structures, and very uniform nuclei, nice round cells. And this should remind you of some neuroendocrine features. And so we did neuroendocrine markers on this, and sure enough, this is a neuroendocrine tumor, a well-differentiated neuroendocrine tumor in the gallbladder. And this looks in some ways like some of those cholesterol polyps, or looks in other ways like just an adenoma, but finding the neuroendocrine markers should help you. And that's to also raise the point that other neuroendocrine carcinomas, including small cell carcinoma, can occur in the gallbladder and be a primary site for that tumor. Those typically do not behave very well. Well, this is the case that I released on my channel today, just a sort of a teaser at the end. This was a 14-year-old boy who developed a tumor in the tail of the pancreas. And this is a tumor that is seen most commonly in the pancreas, but can be seen in other sites as well, which could include the gallbladder. It does include the ovary, may include other retroperitoneal sites. And of course, in a child or a young adolescent, you're thinking of tumors like pancreaticoblastoma or lymphoma, or maybe Ewing's sarcoma or something like that. So they did endoscopy and did a biopsy, and here's the nice acinar epithelium or acinar tissue associated with this. And then here we have cells that look somewhat similar but have a different architecture. As you can see, they're somewhat mixed up with some of that acinar tissue, but they have this sort of papillary architecture. There's a moderate amount of cytoplasm. The nuclei are all fairly low grade appearing. There's round. We don't see mitoses. There are here a few central vessels in some of this. And we went through a number of immunostains with this case, looking at various things. I'll just run through a couple of those quickly with you. This is, I believe, a CD10 stain, which nicely highlighted the tumor cells. Here you see them nicely, strongly positive with this, whereas here our pancreatic acinar parenchyma is negative. Here we see a stain for trypsin, I believe. And here the cells are nice and strongly positive. No, excuse me, no, this is our beta-catenin. So this is our beta-catenin stain, and it's strongly positive in the cells, both in the nucleus and in the cytoplasm, whereas our pancreatic parenchyma only shows membranous staining here, no nuclear staining. So this is really the diagnostic stain. Beta-catenin is characteristic of this neoplasm, and you probably guessed what this is by now. But I will also point out that this tumor can be positive with Well, let's see, this is our, I think this is our trypsin stain here. So this is the negative stain in the tumor, but positive in the parenchyma. And then we also had, I think, a synaptophysin stain, which, or this is chromogranin. Well, this is synaptophysin. So you can see there's some positive staining in this lesion. And this is the pitfall, because sometimes this tumor can be mistaken for a neuroendocrine tumor because of this positive staining. And you'll have some positive staining, nice positive staining in the islets here. But this is a solid pseudopapillary tumor. So I think we'll sort of wrap things up at this point, and it looks like we may have some time for some questions. So what other questions would you like to bring up as we talk in these last few minutes? Are there any other questions about any of the cases?
Thank you very much, Professor. Some case in the gallbladder is benign, but I often diagnose it inflammation other than adenomyosis or adenomyoma. That is rare in my hospital or in my diagnosis, because I often this lesion often inflammation cell.
Yeah, many times they will do operations on the gallbladder, and you'll find very little inflammation. There seems to be also some neuromuscular problems that can produce symptoms without evidence of inflammation or scarring. And it's okay in those circumstances to say, you know, normal appearing gallbladder. We see that as well. Yeah.
Thank you. About the mucinous cystic neoplasm in gallbladder biliary structure, biliary tree. Is it common or not common?
It's uncommon in the biliary tree and gallbladder, but it's probably under-recognized also, because I think people don't know that they should be looking for it, and so sometimes they call it cystadenoma or some other name without recognizing that it's the mucinous cystic neoplasm. But it's uncommon in pancreas and less common in the biliary tree, but both places it may be under-recognized.
I look like the mucinous cystic in ovary.
Yeah, mucinous cystic neoplasm looks like ovary, doesn't it? Yeah.
No, ovary. Yes.
I think the phenotype is distinct from the mucinous neoplasms of the ovary. It's not the same disease in the ovary, but it does look very similar.
Yes. Thank you, Alas.
Okay, well, it's been good to be with you, and we will see you next month. But in the interim, if you have questions, feel free to email me or contact me, and we'll look forward to being together again next month.
Thank you.
Thank you very much.
You're welcome. See you again.
See you.